Good evening, everyone. This is Senator Saud Anwar. Thank you so much for joining in and listening to us. We have a very important conversation we are going to have today, and I am indebted to a number of my friends who are going to share their experience and perspective and help us navigate some challenging areas. So this is something I want you to listen to, and then perhaps you may have to to it a couple of times. In the interest of time, we'll go ahead and get started. I wanted to have one of the first individuals to talk to us, which is Liz Traster. Liz, thank you so much for being part of this conversation. And Liz, you have been a peer support specialist, and you would like to share with us your experience and help us understand what is missing in healthcare right now.
Yes. So this is an account of what happened to me in April of 2022. So it was April 2022, and a combination of excessive stress, insufficient sleep, and an avalanche of triggering events had overwhelmed my brain and shut it down. No longer able to think, to care for myself, to function in the world. Slow, repetitive movements and near psychosis, the only outputs of a brain collapsed. I needed more help. My therapist advised me to call 211, but unable to respond appropriately to their questions, little able to offer more than one-word sentences, the call was disconnected. I had one choice, a choice that I had assiduously avoided for 7 years, a choice riven with brutal memories of restraints and patients screaming in agony and crippling financial debt, the psychiatric hospital. My husband dropped me off at Yale New Haven's emergency room. Fluorescent lights and relentless beeping and patient distress welcomed me at the door. After 8 hours in the hallway, a psychiatric resident evaluated me and told me I was eligible for a bed in the psychiatric unit and that I would have to wait. For how long, she could not say. They put me in the back of the emergency room in the crisis intervention unit in a small, doorless, windowless room with a bed and a TV, and there I stayed for 72 hours. No access to the outdoors, no access to privacy, no access to exercise, no access to the sun, no visit from a doctor or therapist. Trapped in this room, my anxiety and agitation grew, fomenting traumatic nightmares and seductive delusions. I begged my husband and my psychiatrist to get me out, that I would descend deeper into madness if forced to stay in that tiny room. The best guess that it would be several days before an inpatient bed opened. My psychiatrist instructed me to appear as mentally stable as I could, that the unit was a test to see if I could handle the stress of confinement. I performed to the best of my ability for the attending psychiatrist, who apologized profusely to me for the neglect his team had given me, who said it was clear I was high functioning and that I deserved better. He released me, the cigarette-tinged air on York Street, the first fresh air I had inhaled in almost 4 days, the afternoon light beaming across my thirsty face. So bad was this experience, so abysmal in offering the care I so badly needed, so traumatizing and overwhelming that when my suicidal thoughts started in the summer and in the fall, they turned more readily to action, to plans, to gestures, to near attempts, accelerated by the memory of an overwhelmed mental health care system that could not help, that added to the pain, that had failed to give me what it promised it would. This cannot be our only option. We need alternatives. We need hope.
Senator Anwar, you're on mute.
Sorry. Liz, I wanted to thank you for sharing this with us, because the first time I heard you, it brought tears in my eyes about your experience. And I have to say this again, you are a hero. You're so strong. Your willingness to share your experience so that people can do better, we can do better as a state. And I've heard similar stories from literally most larger hospitals in our state with individuals having similar experiences. Um, uh, Jordan, we had talked to you as well about this, and you had suggested what are the ways to approach this, and do you want to share that?
Absolutely. And you know, Liz's story is so powerful and it's so hard to listen to, but it's so important to hear it because there are so many stories like this in Connecticut. And I think one of the things that strikes me about this is the fact that we have a gap in our mental health service system, especially when it comes to people who are experiencing such a high level of mental distress that it would qualify as a crisis. When you enter a mental health crisis in Connecticut, you have a handful of options. Most of those are going to revolve around entering the emergency room or an inpatient psychiatric ward. Those, unfortunately, typically don't have the intended result of reducing someone's likelihood to experience thoughts of suicide or self-harm. And so what we really wanted to talk about today was the idea of how do we reduce harm in the mental health system? How do we reduce the harm of these difficult topics like suicide or self-harm or mental distress? And one place where I think we can start is by talking about the need for a specific type of program that's lacking in Connecticut, called Peer Run Respites. Peer respites use a particular model of service delivery known as peer support services, which utilize people that already have lived experience of mental distress, of sometimes times of crises. And they use that experience to help others navigate through their own distress and crisis. And so when we're talking about peer respite, we're talking about a specific model of peer services. And peer respites are located in the community. They're typically in a neighborhood setting. I have sometimes compared them to a mental health Airbnb. People can go there when they're experiencing crisis, and they can stay free of charge, voluntarily, have access to 24/7 peer support services, which are divested from the idea of liability and controlling your thoughts of suicide, controlling your behavior. It's about what you need to do as a person and your own knowledge of what will help you, and providing the support to that person in that time of need, as opposed to forced treatment, which is oftentimes way more dramatic and has worse results. So this is really about voluntary programs which help people to take back the power over their own recovery and focus on the next steps. I think it's really important to highlight that most of what we would call mental health conditions don't happen in a vacuum. They're attached to very real life circumstances that sometimes make it understandable that we will feel things like thoughts of suicide, that we will cope by doing things like self-harming. And to come at that from a perspective of lived experience, shared lived experience, and compassion to help people navigate through that is so important when we're talking about the idea of recovery. So some of the other panelists that are here today are going to talk about things like liability. I did want to just quickly mention that we know that these types of programs have very long-term cost savings, both immediately from keeping people out of the hospital, but they've also shown to be really successful at keeping people out of the hospital long term. When people know there's a community-based option that's less likely to disrupt their lives, they will take it. And it sets them up for a more successful recovery.
So, Jordan, let me interrupt you for a second and apologize for that. So look, from a medical perspective, the training that we get is to be protective of the patient. And so the mindset that has been created is, look, somebody is going through a crisis, they could hurt themselves. So there needs to be a safety net around that. So do these peer respite places have a safety net? Are they individuals who are trained, who can actually identify who needs what level of care? Because the last thing you want at that critical time is to go into an environment where you do not have a person who's trained. And you can speak to that. And Tom Burr, who's part of the National Alliance on Mental Illness and with Connecticut, you can expand on it too as we continue this conversation. So go ahead, Jordan, you can start, and then Tom, you want to pick up.
Yeah, I would just say that the folks who work in these peer respites, the peer support specialists, are absolutely trained to be able to provide people with the support that they need. It's extremely important for the efficacy of the program, and that has been studied, that anything that happens to someone staying there is completely voluntary. And so that means that if someone's experiencing thoughts of suicide, we offer support, but we can't make the decision for them that they need to be someplace else. And that's why the program is so successful. There's this idea in treating mental health crises that the best thing to do is to lock someone in a safe blank room where they cannot hurt themselves. In reality, it displaces people from the areas and the environments that they feel most comfortable in, and it makes it difficult for people to recover. There's also an idea that even just talking about these difficult topics like suicide and self-harm will be triggering or will make things worse. I'll start by saying that from lived experience, as someone who experiences thoughts of suicide, who has self-harmed, that's absolutely not true. And there are studies that show that when you talk about suicide, when you talk about self-harm in a culturally competent way, it actually reduces someone's likelihood to act on those thoughts, because we're talking about different ways of dealing with those emotions, and we're talking about reducing harm.
Thank you. Tom, go ahead.
Right. And, I'd like to just kind of echo what Jordan said. I mean, as someone who has been a family member of someone who has been at times in mental health crises and has been suicidal, the medical model works for some people. I'm not going to throw it under the bus. It's some people's safe space, but for a lot of people, and my family member specifically, and many others I've talked to over the 2 decades I've been doing this work, it actually is traumatizing, as Jordan explained, to be in a locked environment, sometimes forcibly medicated, sometimes forcibly restrained. And some people just find that more traumatizing. And unfortunately, people with mental health conditions typically have already had plenty of trauma in their lives. And the last thing we should be doing is re-traumatizing them in what's an environment that's supposed to be helpful. And that's why this peer run respite model is so valuable, because it really is a much softer, gentler landing space for someone who is in crisis, who can talk to someone who absolutely knows what they're going through because they've been through it themselves. And again, the data we've seen from the 15 other states that are already doing this kind of work in the country is that the outcomes are really positive. People often never even have to go back to peer run respite, let alone go back to the hospital. So having someone there who, again, has similar lived experience, but has the training to be able to work with someone who is in crisis and provide all these, not only empathy, but also alternatives, as far as different paths of recovery and can talk through the immediate crisis is just really a great model. And again, has shown great promise in the states that are already doing it. And I think it's long overdue here in Connecticut.
Thank you, Tom. I heard from you that 15 states are already doing this, and that's part of the state's policy that train individuals rather than psychiatrists or emergency room doctors in the right setting, but who are trained to identify the high-risk situation, can intervene and provide a safe space for an individual and then help them be in a better place and then go through that crisis in a manner where they're not waiting in the emergency room for 72 hours for a bed. They would still be able to physically stay in those spaces, or they just would be able to stay during the day. How does that work out?
Now, typically a stay is like 7 to 9 days tops, and some people don't need that long. But they can come and go if they want to continue to work while they're working through their crisis, or they've got a pet at home that they need to feed, a dog to walk, or they just want to get out and get some fresh air because that's what they need. That's the beauty of this model. There's no locks on any doors other than the bedroom doors that people can lock if they choose to at night when they go to sleep.
This is counter to the conventional thought process. And when I heard you and others and Jennifer talk to me, I said, look, wait, you're telling me all the books that I've been reading in the past were wrong, and what we have been learning all these years is wrong. So this was quite different. So Jennifer, you share with us your perspective, because you are doing something very interesting around this very issue.
Yes, thank you, Senator. So yes, I coordinate a program through Advocacy Unlimited called Alternatives to Suicide, which is developed by another agency in Massachusetts called Wildflower Alliance. And this program seeks to answer one question. And it really ties in everything people have been saying, or the panelists have been saying. Where does someone go if they are having these thoughts of self-harm, suicide, and they don't know where to go, and they know if they go to the ordinary model that they're going to be locked up, they're going to be put in a room with white walls, may have their belongings taken from them. There was a 2017 study in Journal of American Medicine that actually looked at this phenomenon and saw that people who are hospitalized not only are traumatized, but oftentimes they have trauma for years after hospitalization, and they're actually at elevated risk after they come out, during their stay, and at least months, years after. So this is something that, as we can see, is not working. And so what the network I am trying to build with the help of my facilitators and the people with whom I work is to provide these spaces where people can have frank conversations with peer supporters, with people who have lived experience. All the facilitators are trained, have lived experience, and they hold a group space where people can talk openly, frankly, about what it is to have suicidal thoughts. And the best part, and what makes it the most radical, is that these do not involve non-consensual active rescue, which is someone being taken to the hospital against their will. People can talk openly about whatever's going on with their lives. It's causing them to be suicidal, and they can relate on that level. And people find this very healing and effective. And there's actually a study in Massachusetts in Curtis University School of Occupational Therapy found that the alternatives to suicide approach actually changes people's relationship to suicidal thoughts, which is really interesting, because we know the medical model wants those thoughts to stop. But for many people, we live with this for years, on and off for many years. And really, it is far more effective to have a model that embraces community and would fit really well in the peer respites and would actually change people's relationships to thoughts that are not guaranteed to go away, even if they're on medication.
So Jennifer, this was very uncomfortable conversation for me when we had it the first time. And I said that, look, we talk about trigger alert every time there's a conversation. We say, hey, trigger alert, don't talk about this. And that's how I understand this. But you're saying the trigger alert part is not real, or is it real? And help me understand that.
Thank you, Senator. And I want to validate that fear, and that it's very understandable to have. So for some people, content warnings or an alert like that could be really helpful. But for others, it actually can be a huge relief to talk about it openly, to not have it stigmatized behind the closed door, to not, just go through an assessment and be judged based on this experience. Oftentimes people welcome an opportunity as long as it's asked with a lack of judgment and with openness and empathy to talk about this. And there can be a huge relief from personal experience and many people that I know. Liz, you'd like to speak to something?
Go ahead.
Yeah, I wanted to relate a story that happened to me in college, in which I was open about having thoughts of suicide. I admitted that to my counselor, and the school responded by sending 2 police officers to drag me off the campus and force me into a hospital and on a medical leave against my will. That resulted in me losing identity and purpose, and increase the thoughts. So that fear response that actually ends up causing a lot of trauma and dislocation for the individuals who are very vulnerable in those places.
Thank you, Liz, for sharing that. And then I think the way the healthcare system is trained is to be legally protective, and at times at the cost of losing focus on being patient-centric. And all the facilities, as soon as this conversation happens, we say, let's be very legally protective and find the safety around that, and drug the individual so that they may forget things. But again, there's not one thing that fits all. But so Jennifer, you just finish your thought, because I want to have Jeff Santo weigh in too, because he has a fascinating perspective too.
Sure, thank you. So I have 2 last points, and a major one is, as you were saying, oftentimes I get the question around, well, having people who are suicidal together, isn't that just going to, like you were saying, trigger them more if they're all in a group and they're talking about it together? Won't they give each other ideas? So again, that fear mentality. One thing I like to say is, well, think about how Alcoholics Anonymous was treated a few decades ago. And it was a very similar thought. It's like, if you put people who struggle with alcoholism together in a room, won't they just encourage each other to drink and try, different ways of using? And what we found, and what the peer model consistently has shown, we know that AA is now recommended in the clinical world, and it's really been seen as very legitimate, like a picture of legitimate in terms of peer support. And it's the same way with suicidal thoughts and feelings. People are not encouraging each other to take their lives. They're actually asking each other, what does it take for you to stay here? What has to die so that you can continue living? And one last part I'd like to say is, you were saying about the clinicians who get concerned and needing to take responsibility and liability. I think it's so important to bring it back to peer respites and those alternatives, because if we really care about zero suicide, that's something I hear a lot about, zero suicide and making sure nobody takes their lives. I say, if that's really where we want to go, if people really are fighting for that, they need to consider all possibilities. And that's something, there's enough evidence and studies that show this, that the system status quo is not working for many people, that we owe it to public health. We owe it to each other as a society to try different ways of doing things.
Thank you, Jennifer. And Jeff, share your perspective and with your background, because that's very valuable when we met first.
Well, I'm a recovery support specialist. I was trained through Advocacy Unlimited. And basically, as a recovery support specialist, I'm someone who identifies with either a mental health challenge or someone recovering from addiction. My particular focus is on the mental health side because that is what impacted my life. There is no good reason why I should be alive. I did attempt to take my life at one point in time, and it's a sheer miracle that I woke up in the hospital. And ever since then, I struggled to try to find a reason, what drove me to that point. And as I started talking to a lot of people in the professional arenas, they kind of focused that, hey, this is something that's wrong with you. It wasn't something that was going on in my life at the time. There are people who believe that those who are experiencing suicidal ideations, we just wake up one morning and we decide not to be here anymore. And that's generally not the case. We have people in our society who want to shut something off in their life, something they can't control on their own, something they want to escape from. It could be a domestic violence situation. It could be bullying in a school. We've seen a lot of young adults take their own lives because of this. And we need to create resources that specifically address those problems and try to solve those problems for those individuals. One of the groups I'm eager to focus on actually are law enforcement officers. A law enforcement officer might not feel comfortable going to a traditional treatment provider because, as you said, the provider's instinct is to keep that person safe. And in many cases, that would mean removing the firearm for that individual's possession. And at that point in time, the individual is no longer a police officer. They would literally jeopardize their career by going for help. In an April 11th, 2018 article, USA Today had a headline, "Silence Can Be Deadly." And they pointed out that in 2017, we lost 46 police officers in line of duty deaths, and we had 140 die by suicide, almost triple the number of people who died while on duty. In April of 2019, WSHU Public Radio reported that between January of 2016 and December of 2018, 13 of the officers who died were in Connecticut. And the most updated one that I've seen was back in 2020. Basically, as the pandemic was we were really starting to understand what we were looking at with COVID. USA Today again reported that 228 officers died by suicide in 2019. And again, that's more than that were killed in the line of duty. We also need to create a safe space for veterans, and I'm mixing veterans and police officers for a reason. According to the Department of Justice, nearly 25% of all of the law enforcement officers today have a military background. And according to the National Veteran Suicide Prevention Annual Report, that's posted on mentalhealth.va.gov, right on their website. Since 2005, we've been losing an average of 17 veterans to suicide every single day. And I think that the more options we can give to people who are in the community who are afraid to report this to a professional, I think the better it's going to be for them, and we can keep more of them alive and with us and serving our communities. The last thing that I want to mention with the Peer Run Respite and the alternatives to suicide, we talk about what are the risks of allowing basically lay people to get trained in what's basically 80 hours in a couple specialty classes. What gives us the ability to help somebody facing suicidal ideations or other mental health or addiction challenges? And the answer is we use our lived experience. Now, that might not be the same as a college degree or a PhD, but we had an incident on the Connecticut Valley Hospital campus back in, it was 2019, where a social worker working on the CVH campus took her own life. And this is a person who is surrounded by trained professionals who are specifically there to help folks through those types of thoughts and ideations. And out of all the professionals she worked with, none of them had a clue what she was thinking or what she was about to do. My point is that no system is perfect, and whatever program we come up with, it's going to have some element of risk. But I believe that there is a much bigger risk by not taking these steps to try to create more options for our communities.
Thank you, Jeff, and thank you for your courage to share the perspective and those very concerning statistics. And I think the what the point that you have made, and especially in law enforcement, is as soon as a law enforcement officer is going to say that they have those feelings, their guns will be taken away from them. That's what some of the policies are, and the person loses their identity because their purpose is to protect everyone, and then suddenly that protection is taken away that they have for the purpose, and then that would not help the situation. So it's not an easy path. Jennifer, can you expand on what kind of a training would a person have who's going to be, or actually anybody else can add to that, is the training for a respite peer support person?
Well, I can speak for alternatives to suicide. There's a 3-day training and ongoing support in the form of networking calls and connecting with the peer community. And another thing about groups is that they're fully anonymous. As like say a law enforcement person or anyone could come and they can continue to go about their lives and just seek support in that way without that risk that Jeffrey was talking about if they go through the clinical model. In terms of peer respite training, for peer respite specifically, I'm going to defer to Jordan.
Thank you. Go ahead, Jordan.
Absolutely. So I'm familiar with a lot of folks that run peer respites around the country. And what is extremely common in peer respites is to have, I mean, definitely some sort of peer support training. Specifically, what's very common is what's called intentional peer support training, IPS, which was developed by a person named Sherry Mead in Burlington, Vermont. And it was developed by people with lived experience. The whole point of this training, which every time that I hear someone talking about it, I hear praise for it, is that it is really focused on questioning our own assumptions and finding ways to use our lived experience to relate to the people that we're working with. So in the context of peer respite, this means that, you know, if I am someone that's lived with thoughts of suicide, I'm not afraid to have a tough conversation with someone. If someone's coming to me and saying something that it sounds a little concerning or questionable, I have to think about, why might I be reacting this way? And what kind of response, what kind of support can I offer to this person to give them the best experience possible to help them turn this crisis into an opportunity for recovery? And so that's really the focus of these types of programs, especially harm reduction.
Thank you. And go ahead, Jennifer.
I did want to expand on something you said, Jordan. Not only is on top of all of that, intentional peer support has a firm culture of co-reflection. So when peers work together, they will regularly come together in co-reflection and talk about, you know, what worked, what are other possibilities. So they're always reflecting and within themselves and back at each other, what could be done better every time. So there's a ongoing culture of growth and seeking to understand. So I really wanted to throw that on there as well.
And Jordan, when we were speaking earlier, we talked about respite, which is going to have affinity group-based respite. Can you expand on that too?
Yes. So one of the proposals in Massachusetts that's being floated right now and considered by their state legislature is to one, expand the total number of peer respites that exist in that state from, I believe it's 3 right now, to 14. 12 of those would go to provide a peer respite in each county of Massachusetts. 2 of them would be specifically focused on the LGBT population. And I mean, especially like as a trans woman myself, it is so incredibly important that there are spaces where we can talk about the many things that we are feeling that don't come up out of some sort of abstract concept of whatever's, wrong with us. Rather, it's an effect of the way that these groups of people experience severe systemic discrimination in many different aspects of their life. And when we talk about peer support and we talk about that training, I think it's important to point out that one of the most important components of peer support is the idea of mutuality. It's the idea that when you are seeking support from someone, that the person who is available to you and the person you're developing a relationship with shares your lived experience, which is why it's so important that especially trans people, Black and brown people, have people that can relate to the systemic struggles that they are burdened with. And I think especially in Connecticut, there is just a woeful lack of mental health services in general for these populations, especially the trans population, even more so with peer services. And it's so necessary when you see things happening around the country that look like forced outing or forced treatment. It was not so long ago that being LGBT was considered itself a mental illness. And so there's a lot of trauma from the way that we have been treated by the medical system. And peers are really here to answer for that. And especially when you have a relationship with someone who shares your lived experience, it's so much easier to start from that basis.
Thank you for that. I have some people who have asked some questions, so I just wanted to ask the questions. Paul asked that why would the peer respite be held to a higher standard than quote unquote service?
I think it's a great question. And, I'll just say, when you look at the rates of suicide and self-harm in our current medical hospital system, in our state hospital system, these are things that happen all the time there, unfortunately. And what we know about peer respite is that they do not, the ones that exist around the country, are far less likely to experience any sort of high-level risk incidents that has turned into a suicide or things like that. It's not that it's impossible for it to happen. It happens in every single mental health program that handles people in crisis. But that's part of the reason that these services are so important. I also just want to point out that we were lucky to work with some law students from the Yale School of Law this past spring, and they did a lot of digging into the liability question. And peers are not held to the same liability standard, which means that they're able to have these flexible discussions with folks. They don't have a duty to prevent. We're here to support. And so funny enough, that's what the evidence points to as being the most successful.
The first time we spoke, in the end of our conversation, I said, I'm going to go and call some of my friends who are psychiatrists, because you are telling me things that are so non-conventional from my historical understanding of things. And I reached out to a very credible psychiatrist I have very deep respect for. And he validated everything that you guys are saying. He said, well, that's what's showing more results right now. And at that point I said, oh my God. So, and this is where, and that's when I reached out and said, we should have a conversation to actually try to get more people to listen to this perspective. And while 15 other states are doing this, perhaps it's time for us to start the conversation and see what can we learn from what's out there, and make sure that the citizens of Connecticut are not short of options for them. Because right now we have another entire conversation happening that why there's such a large number of people waiting in emergency departments in all hospitals because the healthcare system has its challenges at this time, that we are adding this on top of that, and they're just thinking that put this person in a room and forget about them because at least they will be safe. They'll be miserable, but that's the problem. It's not helping the broader picture, and we are not humanizing the agony of a person who's going through being in that environment. So another question that came up was from Emily, asked that, do you support holistic approaches to mental health care? Everybody's nodding yes. Okay, good. That's all right. That's a resounding yes. And what kind of holistic support? Could you expand on that? Yeah, go ahead, Jen.
Well, I'm working, so my program is not just part of Advocacy Unlimited. I do work for a part of Advocacy Unlimited called TOIVO, and TOIVO Center, I mean, that is the heart of it, is the center where everything's donation based and people can come as they are. Nobody gets turned away for funds. And we offer activities such as yoga, qigong, drumming, sound healing, watercolor. We offer a lot, and it's because the folks with lived experience, namely Darren Drum, who founded TOIVO, was someone who struggled himself. And he found that these alternative practices, and all of us who work there have found that they were instrumental in our recovery. And they gave us that alternative, and they gave us a way of connecting with ourselves. These one really damaging message sometimes the clinical system sends is to not trust ourselves. And I feel like that really perpetuates some of the trauma, because many of us who've been through trauma were given the same message: don't trust yourself, trust somebody else instead. And what these holistic practices do is bring us back to ourselves, to a place where we can trust ourselves. And people with diagnoses are perfectly able to do that, just as long as they're given the right opportunity.
Thank you. Jordan, you wanted to weigh in too? Yeah.
Yeah, I just wanted to add to that, and I'll try and keep it brief, that I was lucky to visit a FIA house, which is a peer respite in Massachusetts that's been cited by the World Health Organization. And you go in there and they have everything that Jennifer was just talking about. They have drums, guitars, books on the wall, so many books that you can read. They have TVs if you just want to veg out and watch TV. There's conversation spaces. They have yoga mats. You can cook your own food. And that is something that's common in every peer respite that I know of.
Thank you. Tom?
Yeah, and again, as someone who comes at this from a family member perspective, and when my family member first became ill, which is going on 25 years ago now, I thought all this person had to do was go take some medicine and they'll be fine. And it really, over the course of these past, 20 plus years, I've realized that it's so much more than that. And for some people, it doesn't include medication because they've been harmed by medication. Everyone's path to recovery is different. But when I talk about the different alternatives, we talk about everything in a holistic fashion: diet, exercise, sleep, environment, getting out into nature, all these different things, and all the nice, cool therapy and fun stuff that Jennifer was just talking about that they offer at TOIVO. Whatever that stuff is that resonates with you, then that gets you connected, not just with yourself, but with other like-minded people, because we are social animals. And unfortunately, because of the stigma around mental health, too many people, when they start struggling, just want to isolate themselves because they don't want to be further stigmatized and looked down upon. And that's dangerous, because we are social animals and we do need to connect. And having places like TOIVO and places like the NAMI peer support groups, places where people can connect with like-minded people who are working on their recovery, is just so important for folks. And it's just nice to have this stuff available now that wasn't nearly as available 25 years ago.
Thank you. We're getting close. You go ahead, Liz.
And I think, one of the things that, many of the things that have been so instrumental for my recovery, my mental health, and many people that I know are not that available in the psychiatric hospital. There's limited access to the outdoors, there's limited access to nature, there's limited access to exercise. And so for so many of us, not just those of us with mental health conditions, but people who are neurotypical, those things are so nourishing for mental health. And doesn't it make sense that like if you're in crisis, you would need that even more?
And another question has come from Elsa, who's talked about the safety net. What would happen if the peer became concerned about the safety of an individual, and would they be able to reach out to a crisis team at that point? Jennifer, you want to take that, or Jordan or Tom?
I'm happy taking it. Look, I think that the reason that we need these types of programs is because the existing programs are just full of this aversion to what is perceived as a risk. And like we said, we can't get away from risk when we're talking about things like suicide and self-harm. That's the reason we need these programs. What I can say is that as someone that has very frequent thoughts of suicide, as someone that self-harms, I will not enter a program where, and I will not seek help if I'm aware that that program could lead to me being forcibly taken to a hospital against my will, especially as a trans person. And what we know from existing peer respites is that when polled after their stay, guests at, for example, a FIA house said that, yeah, many of them would go to a hospital, many of them would go to a crisis respite, which is more clinical, a slightly different model. But there are many of them that just say they're not sure where they would go. They wouldn't seek out any services. And so what we need to do is focus on creating a space where people will feel comfortable reaching out for help. And it's that person's decision what to do with their own recovery.
And Jeff, go ahead.
One of the things that I do want to point out is that a community respite run by peers, it's not something you can just pull in the driveway and say, hi, I'm here, give me a bed. There is an intake process, just like any other program, where a staff member would sit down over the phone or even maybe meet in person to get an idea of where someone is at. For example, we have what we refer to as co-occurring, where you have somebody who's dealing with a mental health challenge, and they might also be struggling with addiction. If I were talking to an individual and I learned that that person had been using drugs and might detox while they're in the respite, I'm going to say, you know what, we're not medically equipped for that. That is something that's way outside of our wheelhouse. The one thing that I want to kind of assure all professional providers is that we know we don't have a cape, we have a certificate. And we know not to bite off more than we can chew, and their safety, as well as the safety of everyone else in the respite, is our primary concern.
Thank you. That's very reassuring, Jeff. Tom, please go ahead.
Yeah, I just wanted to kind of echo something that Jordan touched on a moment ago. And I just can tell you that I've just run into so many people in my time in this space that feel the same way that Jordan does. Just they will not willingly go into a restrictive environment, period. They often won't know what they're going to do, but that's just not an option because they've had bad experiences. My family member was in that same boat. It got to the point after several hospitalizations that they decided that was it. They're never going to go back to a hospital, no matter how bad things were. So it's just not that, again, the hospital isn't a safe space for some people, because it is. Some people, that's what they prefer. But I found there's an awful lot of people, I don't have a firm number for you, but it's significant, who are that's just not going to work for them due to past experiences.
And Peer Respite staff will stand ready to provide people with information about those resources if that's what they want to do.
Yeah. I think, as I understood this, there was a pyramid that majority of the people would benefit from the peer respite. And then there are ones who have much more significant needs. They will go to a next level of care. And the ones who have even significantly more challenging issue, they would actually go further at a much higher level of care. And majority may not necessarily need to be at the highest level of care. And that actually reduces the total burden of everybody seeking the highest level of care when it's not necessary in most cases. So that's, I think, how I understood it as I was reading more about this. We could talk about this forever, but I want you to know I can't thank each and every one of you enough for sharing your experience and a difficult experience, but you're doing it from a place of love and care, because you're trying to make sure that the others who are experiencing this, and God knows everybody else in our community knows somebody or they themselves may be experiencing this. And this is the time for us to start to look at the models that are going to be more effective. And this is not coming out of the blue. You're not picking it out of a hat. This is something that people have shown to be effective. And your experiences, what you're talking about, are something that we have heard not from you alone, but other people out as well, that the existing system has flaws. And it's time for us to start to put our heads together, look at what's out there, what works, what does not work. Is there an opportunity to do better for the people in our state? And your lived experience, your shared experience, your cared experience is very valuable. So thank you for joining us. And for people who are listening and who have watched this, may I ask you to please watch it again and also share it with the individuals who may benefit from this conversation, because I think we as a state need to have conversations around this. And perhaps if other leaders in the state think that it's worthy, we should talk about policies around this topic. So with that, I wanted to send each one of you a virtual hug for being so kind and then special and giving. Thank you so much.
Thank you, Senator.
Thank you so much,
Thank you,
Senator.
Senator.
Thank you, Senator.
Thank you
Thank
for your
you.
kindness.